Vergnon from the, yes, I am Professor Vergnon from the University of Saint-Étienne in France. I was the founder and the past president of the JETIF group. The JETIF group is an international group of French language dedicated to interventional pulmonology. And I chair the group of academic affairs and educational from the WABIP. So we have 3 speakers today for this webinar dedicated to airway stenting. The first will be Professor Hervè Dutau from Marseille. Hervè Dutau is a well-known interventional pulmonologist. He had organized with his colleague Philippe Astoul the last WCBIP Congress in Marseille in 2022, and his mentor was Dr. Jean-François Dumont, who have invented the famous silicone stents. So Hervè had a huge experience in stents and in silicone stents. Hervè, you have the microphone to the first presentation on silicone stents.
Can you see my slides?
Yes, of course.
Okay.
20 minutes.
20 minutes. Okay. So I try to remain on time. So thank you, Jean-Michel. I'm also happy to be present at this webinar with Nicolas and Karen. And I am often asked to speak about silicone stents because, as you mentioned, Jean-Michel, the silicone stents were born in Marseille. So first, I have to disclose that I have this conflict of interest because I am consultant for Novatec, who is the sponsor of this webinar. Novatec is a company which produces both silicone and metallic stent, and it's in a small town close to Marseille, La Ciotat. So yes, the modern era of airway stenting started in 1987 in Marseille, thanks to my mentor, Jean-François Dumont, with this very simple idea of a silicone tube with studs around to prevent migration. And you have the first publication in chest in 1990. And at that time, when I discussed with Dr. Dumont, it was a little bit controversial, and some colleagues were reluctant with the idea to place a foreign body in the airway. But we know the story, and it proved to be efficient. And the first silicone stent, on the left upper part, were coming into 2 kinds of stents, transparent or white, because they were filled with barium in order to be radio opaque and visible on the X-ray. And now the silicone stent, the Dumont stent, are like this, with studs, radio opaque studs, in order to be visualized on imaging. At that time, other silicone stents came into the market, both straight, like the Hood, Polyflex, Novastent, Nopen. But I think, and to my knowledge, only the Polyflex is still advertised. And then they came into bifurcated waist stents for disease at the level of the carina, both main carina, but also secondary carinas, but we'll discuss about that. And this last one, the Oki stent, is meant to treat disease at the level of okay, I cannot go back on the right side. In 2010, Lutz Freitag, who is very famous in airway stenting, has listed these 5 indications for airway stenting in general. So I don't speak about metallic stent at the moment, and I will let Karen speak about that. So extrinsic compression, that's clearly the best indication. Stabilization of airway patency after removal of intraluminal growing cancer, treatment of benign strictures, stabilization of collapsing airways, which is very controversial, and treatment of fistulas, like stent dehiscences or tracheoesophageal fistulas. J'arrive pas à passer. Why cannot? Okay. So when in 2018, when I was president of the European Association, I wanted to have an idea about the practice of airway stenting in adult population in Europe. And so I asked to 26 countries in Europe, each correspondent of each country has to answer some questions, but just one question was about which stent is the most placed in your country. And you see that at that time, the two most placed in Europe were the Dumont and Ultraflex. So clearly in the literature, you will see that again. And that these are the two main places in the world, Dumont in Europe, Dumont and Ultraflex. So rapidly, because I'm often asked this question, which one is optimal? Is it silicone? Is it metallic? And I say it at once. I have no answer, because there is no answer to this question. There is no objective answer regarding the available scientific data. There are very few comparative studies. And what you'll find is mainly monocentric studies, both on silicone, on the Dumont or Ultraflex, in benign, malignant. So level of proof is very low. It's COD, it's expert opinion. So if you don't mind, today I give you my expert opinion, and it's only my opinion. But by the way, if we have to list the theoretical characteristic of what should be an optimal airway stent, it should be cheap. I won't speak about price because it varies a lot according countries. So, but just as an example, in France, silicone stents are cheaper than metallic ones, but it's only for France. Then second characteristic would be easy to place, easy to remove. The stent would have no or few complications, would be suitable for most of the indication and adapt to some peculiar situations. First of all, what about placement? Silicone stent requires rigid bronchoscopy. You cannot escape from that. So if you are trained and skilled in rigid bronchoscopy, placing a silicone stent is not difficult. But you know, it's not self-expandable. So you have to make the place for the room for the stent. And so you have to achieve maximal dilation before placement. And generally, you place it blindly, distal to what you want to treat, and then you have to pull it back onto your lesion. On the other hand, the Ultraflex can be placed with a flexible bronchoscope, plus or less fluoroscopy, and do not require an optimal dilation because it's self-expandable. Just to illustrate what I was saying regarding silicone stent, you see, this is a typical aspect of silicone stent placement on a benign tracheal stenosis. And just after insertion of the stent has to be a little bit folded. You have to fight with it. You have to struggle to open it. Otherwise, if it opens too easily, the stent will migrate. So you have different techniques, either like in this case, placing a smaller rigid tube in order to iron the fold, or you can place a balloon. What about easy to remove? Silicone stent are easy to remove, and it's possible anytime, like in this video of a stent which was left in place for 1 year and also requires rigid bronchoscopy. On the other hand, difficult when the Ultraflex is very difficult when the non-covered part are not re-epithelialized. So requires rigid bronchoscopy most of the time. Not always. If you don't let the stent in place for too long, you can remove the Ultraflex with a flexible bronchoscope, like stated in this group from Israel. What about complications? It's average complications. Silicone stents are known to have as main problem migration, but you see it's about 10 to 17%. It depends largely on the indication. But like if you put it for tracheobronchomalacia, you have a risk of clearly of migration. Then you have granulomas, you can have obstruction by secretions, and bacterial colonization in 78%. On the other hand, the main problem of the Ultraflex is granulomas because of the non-covered part and the bare metal in contact with the mucosa. And something which is very specific to metallic stent is the fracture. The silicone stent cannot break. Why? If a metallic stent is left in place for a long time, it can break. Otherwise, you have. But whatever stent you place, you have to expect or at least to attend, that you will have to face complications. What about indication? In benign, a good point of German stent, as I said, is easy to remove, so it's removable. And again, what is very important is that you don't worsen the primary lesion. It has been showed in both in tracheal stenosis and also in lung anastomotic anastomosis complication. So you don't worsen the primary lesion. While the ultraflex, and it's not from Marseille that we say that, it's a group from a surgical group from Boston, very famous, from Grillo, who showed that ultraflex was worsening the primary stenosis and make impossible the surgeries that could have been performed in 30% of the cases. So it was published in 2003. So in 2005, you had this warning from the FDA regarding the use of metallic stent, and I have to add, and I had it in purpose, non-fully covered metallic stent for benign tracheal stenosis, that you have to avoid that. You should avoid that. You should consider first surgery, which remains the gold standard, and then after silicone stent, and if really you insist on placing metallic stent, but you have to be trained in placing them and to remove them. Mark Nopen in Chest 2005 showed that it's very difficult to remove ultraflex, and he found that only 26% removal was performed without major complication. That means that 74% had major problems to be removed. But now, and Karen will speak about that, I think to overcome this issue, we have the new generation of fully covered metallic stent, and I won't go into detail because Karen is going to speak about that. What about malignant condition? So just two papers, just to say that whatever stent you place, most of the patients have the same survival, same 6 months or median survival. So it's not a real problem to choose both stents. Very few comparative studies, but at least one from Barcelona, from our friend Tony Rosell, where he studied in 5 years a group of patients treated with either silicone stent or fully covered metallic stent. And rapidly, you see there is no statistical differences between the two stents in terms of mucus retention, granulation tissue, migration, and also in terms of survival. So no differences between the two kind of stents in this study. And very recently, it was issued and published in May 29th of May, so this year, the World Association for Bronchology and International Pulmonology Guidelines on Airway Stenting. So I encourage you to because it's open access, so you can easily get a PDF of the paper, but just one slide showing that in malignancy, straight stents on the left, wide stents on the right, silicones in red, metallic in blue. So you have complication indeed, but not a big differences, except maybe the granulation with a wide metallic stent, which are higher than with the silicone stents. Something which is very important when you want to stent disease is what we call the secondary compression, which is the ability of the stent to be compressed by the compression. So in other words, what is the radial force of the stent? Will the stent will be strong enough to counterbalance the pressure? And in his review in 2010, the Freitag showed at that time that silicone stent, Nopen, Polyflex, Dumont had a higher radial force than the metallic stent. To be honest, I think it has changed. It has clearly changed. There is no more recent data, so I cannot show you. But now some fully covered metallic stents are quite strong, and mainly the wide stents sometimes are stronger than the wide silicone stents. But it's important to know the radial force of the stent you want to place, according to the situation. Now, some limitations of the silicone stent. Silicone stent when you want to treat a curve, curvilinear lesions, silicone stents remain straight. They don't take any curve, while metallic stents adapt better to curves. So in this particular situation, it's probably better to place this kind of metallic stent. And another limitation of silicone stent is that I found that they are not perfect to seal air and liquid leaks. And if you look carefully at this picture with a tracheoesophageal fistula, and you see the metallic stent of the esophageal metallic stent, and after placement of silicone stent, you see clearly that if there are remaining aspiration, they will go here and here because the stent does not fit perfectly the wall. And so in this situation now, I have to say that I prefer to place a fully covered metallic stent in this situation. Another limitation of silicone stent is that it's very rare. When you have to treat very large airway like tracheobronchomegaly, Muni-Kuhn syndrome, you cannot place, or at least Nicolas will say something probably different, but with the existing loading system, you cannot place more than 20 millimeter silicone stent. So above 20, only metallic stents can be placed. So it's a limitation. Otherwise, you can place a silicone stent, but using a forceps or a laryngoscope, but not using a real bronchoscope. What is, in my opinion, the main advantage of silicone stent is that on-site customization, which is not possible with metallic stent. And you see, you can have the possibility to make to create an orifice, a hole in the stent, and you don't jeopardize the mechanical properties of the stent. And of course, if you do that with a metallic stent, you break the stent. You have it's completely broken. So it allows you to put a stent and to still ventilate a lobe that could have been covered by the stent, like in this case, right upper lobe. On-site customization is always the case with Y stents. Because Y stents, when you open the box, it's a sterile box, you have 11 centimeter in the trachea and 5 centimeter in each limb. So of course you never place the entire stent. So you cut each branch according to your need. You can eventually also insert another one at one limb. You can customize a small Y stent for the left upper lobe. I often do customization of T-tubes for the right upper lobe. So silicone stents, that's the main advantage, is that you can customize the stent. And then you have this kind of results where left anastomosis, stenosis after lung transplantation, and after placement of a T-tube. In this case, it's the T-tube, but it would be the same with a Y stent. So there is a branch of the left main bronchus. You see the branch going to the left upper lobe here, and before, an orifice has been created to prevent, to cover the uptake of LB6. So in summary, I try to remain fair, which is sometimes difficult in Marseille. But you see, this is my summary. Easy to place, probably metallic, but depends. If you're skilled in rigid, it's not difficult to place silicone stent. Complication, I would say it's equal. Benign is better with silicone stents. Curves better for metallic. Fistulas also large airway, but customization is very the main advantage of silicone stent. Just as a warning, because I spoke about stent-related complication, but I like to recall that physician-related complication is something quite often, quite frequent, because rather than blaming the stent, sometimes blame yourself about, is it a good indication? Was it a good stent? Did I put a good diameter? If I have an obstruction, did I prescribe saline, which is mandatory to prescribe saline? And something very important called patient or disease-related complications. So in other words, if you take two patients with the same disease, you place the same stent, and one patient will have no problem at all and will come back. In Marseille, we change every year, and we'll come back at 1 year without any problem, just for stent change. and another one will call you 3 weeks after because he has obstruction or granulomas. And this is some factors that we don't know very well. It's inflammatory reaction, maybe immunologic reaction, but something we don't know really. So in 2017, it was the 30th birthday of silicone stent, and I was asked by Atul Mehta from Cleveland to make an editorial in Journal of Bronchology and International Pulmonology. So it's the first only paper I have in common with Professor Dumont. And so in this editorial that I particularly like, we have listed all our experience regarding airway stenting. One sentence which looks obvious and easy to read. So you have to place a stent when the benefit from stenting appears technically feasible and clinically meaningful. It sounds logical, but it's not that easy to understand. I think that I've spent first part of my life trying to reach my technical skills, and I was not that much thinking about, was that very clinically meaningful. So something that you learn with time and experience. Airway stenting is a palliation, in my opinion. It's a palliation because you palliate the absence of all medical or surgical options. So you place a stent because you have no other option. But stenting can be considered as a primary treatment in some cases or as a bridge toward other management, like placing a stent in a tracheostenosis before surgery, placing a stent before in a small cell carcinoma or lymphoma to a patient with distress before chemotherapy that you will remove after. So it's a bridge most of the time, but it's also can be curative in a certain percentage of time of patients. A stent is a foreign body and nobody is perfect. Discussion and controversies regarding the type of stents are useless because as long as we won't have comparative studies, evidence-based medicine proof levels are low. And so again, I insist on the fact that in this presentation, I give you my opinion. My opinion is that the optimal stent is the one that you don't place because you found another solution, either medical or surgical. But if you place a stent, you have to be able to remove it in all situations, even in malignant condition. In my opinion, stent placement and removal using rigid bronchoscopy is safer and quicker, irrespective of the stent you place. And just to illustrate something, because Marseille is the birthplace. So when I started to work with Dr. Dumont in 2001, 100% of the stents were silicone stents. And when the fully covered metallic stent came into the market, I started to use them because, again, I showed you, I found that in some particular situation, it's better. And now we have like 65% of silicone and 35% of metallic. And just to end my presentation, because today it looks like a French connection, and I am happy to be the connection between two presidents of the French-speaking group. So the previous one, Jean-Michel Vergnon, and the new one, Nicolas Guibert, who will speak after me. Picture took in Marseille for the World Congress. Thank you.
Okay, thank you very much, Hervé, for this clear presentation and perfectly on time. All the discussion will be at the end of the 3 presentations. And the second speaker now is Professor Nicolas Guibert. Nicolas Guibert is the chief of the Department of Interventional Pulmonology of the University Hospital of Toulouse. He is the president of the GETIF group. He has a great experience in different aspects of interventional pulmonology and had also a great experience in 3D printed stents after lung transplantations. So Nicolas, you have the microphone now.
Thank you very much. Thank you to WABIP for the invitation. I'm very happy to be here and talk about these personalized airway stents. So these are my conflict of interest. I also have worked with Novatech for some lectures and workshops. And I'm going very straightforward to the rationale because we've seen the indication more in detail with Hervè. So what is the rationale behind the use of these patient-specific stents? Well, you know that at least some of the complications of airway stenting are linked to a lack of congruence of the device with the anatomy of the patient. And the more complex the anatomy is, the more likely you will face this type of complication. And that's above all granulation tissue reaction and migration. I don't believe mucus plugging is really linked to the shape of the stent. It's more linked of the surface that will be covered, and we're going to see, we're going to discuss this later. So based on this idea, we started in 2014 a proof of concept study where we have treated 10 patients, all in situation of therapeutic impasse. So conventional stents either failed or were not suited. And we treated 10 patients for post-transplant anastomotic complication, other more complex anastomotic complication after airway surgery, and 3 tracheotomy, post-tracheotomy stenosis. So you can see an example here of the patient that I showed previously. The stents are to be used, to be changed and replaced every 3 to 6 months, and this stent that you see follows better the particular curve of this trachea, remained in place for more than 3 years. So obviously we did not have this type of outcomes for all patients, but what we saw is that first of all, it was feasible. We could place the stent in all patients. It was very well congruent with the anatomy of the patient in 9 out of 10 patients. And we saw improvement in dyspnea, quality of life, and pulmonary function test for 8 out of 10 patients. But this was just a feasibility study with short-term outcomes. And now we are currently enrolling patients in a phase 2 trial, an efficacy trial. This is the Tatum trial, that is a bi-center study between Toulouse and Marseille, so Hervè Dutau. And the methodology is as follows. So we start from a CT scan of a patient that must be done in forced inspiration. Then using dedicated software, we do 3D segmentation of the airways. The most difficult step is probably the virtual correction of the stenosis. So you need to anticipate the first step of your procedure, so usually dilation. And that's the part where there's a learning curve, but we're going to talk about this later. And then we manufacture the stent, but in fact, we don't 3D print the stent, we 3D print a mold, a negative of the stent, an injection mold, in which is injected the same silicone that are used for the Dumont stent. So it comes exactly as a Dumont stent, but personalized. And these stents are implanted through a rigid bronchoscope like any other silicone stent. So the study will have a follow-up of 1 year. We're going to look at quality of life, dyspnea, complication, but this is still ongoing, so I don't have the results. But you probably know also that these stents are also available, commercially available. So there's 2 solutions. For Europe, we are using the Novatech solution. But there's also for the United States the solution that has been designed by Tom Gilder in Cleveland. This is the Visionaire solution. I don't have any experience with it, so I'm going to talk about what I know. But the manufacturing process is basically the same. It's similar with a mold-based manufacturing. So now I'm going to talk about what I believe could be the preferred indication for these stents. This is not a talk on non-malignant airway stenosis, so I'm just going to say that these indications are obviously with the prerequisite that airway stenting has been the solution that has been indicated. So when surgery has been ruled out, when dilation has failed, etc., etc. So now, based on 9 years of these, the use of these stents, what I believe are the best indication are as follow, and in order. The best indication are whenever you have an anastomotic complication, And the first situation and the most frequent situation that we face in Toulouse is anastomotic complication after lung transplantation. We often have a more distorted anatomy. We often have some different angles, and conventional stents usually can be used, but are also associated with a high rate of complications. So we tend to use this type of stents in this situation, in particular when we feel the need will be on the long term. So this is an example of a malacia of the bronchus intermedius in a lung transplant patient. This is another example of a patient with a fibrotic stricture that is very close to the secondary carina. And that's one of the issues that we face, is that the stenosis, the anastomosis is usually close to the secondary carina. And so when we face a complication, it's more difficult to treat with conventional stents. And you see that these stents cover very well the anatomy and usually are well tolerated. Other anastomotic complication, I'm just showing you a case after a sleeve lobectomy. This was a patient that had a right upper lobectomy, sleeve lobectomy with a resection of the right main bronchus, implantation of the bronchus intermedius into the carina. And you see that he developed a complete occlusion of this anastomosis. And usual devices were not suited because of the discrepancy in diameter between the two branches. So we had some deep granulation tissue reaction with self-expandable limbic stents. The right branch of the silicone stent would not unfold due to this small diameter. So we designed a 3D stent, and this patient was treated in our first proof of concept study. You see here the complete obstruction after perforation with electrocoagulation, dilation with the balloon, and you can see the stent that fits well the anatomy with the smaller diameter of the BI, and these stents remain in place for more than 1 year with no complication. This is another example where the curve of the bronchus intermedius at the level of the stenosis were difficult, and conventional devices induce some granulation tissue action. So we use this straight but curved 3D stent that induced a much better tolerance than what he had before. And this is probably the best case to convince about the use of 3D stent. This is a young patient that had a very complex airway surgery. She had a tracheal resection and the carina resection for an adenoid cystic carcinoma with implantation of the right upper lobe, as you can see, in the trachea of the BI to a neocarina, and she developed some stage stenosis, malacia, severe malacia of the tracheal branch here, a complete occlusion of the bronchus intermedius, and she received 15 stents in 27 months in the center from where she was referred. So she was sent with a self-expandable metallic stents, but very different devices had been tried. So you can see a granulation tissue reaction, nothing really severe. The right upper lobe is covered by the stent. Again, some granulation tissue reaction, and you can see that the BI is not very well ventilated. So this stent could not remain in place for a long period. So we designed this double bifurcated 3D stent. This is the immediate results after implantation. So you see the stents that fits well the anatomy, allows for a ventilation of the right upper lobe in the trachea. There's much smaller diameter for the BI portion than for the left main bronchus. So clearly here, we really had struggled with conventional stents, and this stent that you can see on the CT scan fits well the anatomy, remain in place for 18 months. We decided for a systematic change, and also because I wanted to try to dilate more the BI. At the first step, I had to use a balloon to open this branch, but I felt like after a certain amount of time, I would be able to insert something larger. And that's what's really interesting with 3D stent, is that you can really progressively correct the stenosis over time. And I believe this stent is now in place for 18 months as well. And I believe next time I will remove it, I will probably be able to wean the patient from any stent, because it looked much more stable already last time. So let's see. Tracheal stenosis. tracheal benign stenosis, non-malignant stenosis, so post-tracheotomy or post-intubation. I don't believe there are usually some good indication for 3D stents. It really depends on the outcomes that you've had, the complication that you have had with conventional devices. But usually if a straight stent migrates in a patient with not a particularly complex anatomy, 3D stents are not going to do much better. Hourglass shaped stents are probably the best indication here. I would say the exception is in this type of patients with complex anatomy, post-tracheotomy, where the sequela from the cavity of the tracheotomy allows you to design something that will be stable, so with a patient-specific anti-migration structure. So this is an example of a patient. Here you can see that she had different migration, but she also had, as you can see, some dramatic granulation tissue action at the upper extremity that was oversized. It was on the opposite undersized at the distal extremity. So we designed a stent that, as you can see, would use the previous cavity of the tracheostomy to stabilize the stent and would fit better the anatomy. And again, the stent remained in place for 18 months, was removed, and since then, this patient had much more stable airways, and this was 6 years ago, and we did not have any further bronchoscopic procedures for this patient. So I think that's also a case that highlights pretty well what I believe is that with personalized stents, probably if you fit well the anatomy, if you induce less mucosal trauma, and the stent can remain in place for a longer period, it's possible that we also ultimately have a higher definitive healing of the airway stenosis. Okay, and fistula, bronchopleural fistula, complication after lobectomy or pneumonectomy is not a well-recognized indication for airway stenting, usually because it doesn't seal very well the fistula, among other factors. I'm just going to show you a case which is more anecdotal than anything. This patient had a very large bronchopleural fistula, as you can see on the bronchus intermedius. He already was treated with open window tracheostomy. But the thing with this patient is that he could not speak. He had a severe aphonia due to the air leaks through this huge fistula. So we designed this kind of Oki-like stent, but with an occluded distal end that, as you can see, plug the fistula. You can see from the open window thoracostomy, and you can see the bronchoscopic results here. So you can see that it seals pretty well the fistula. And so I will probably try in the future to use this type of devices before considering some more invasive and definitive treatments such as open window thoracostomy. And you can see on the CT scan that the congruence is good and it seals pretty well the fistula. But this is not, again, this indication really remains to be investigated. But the biggest question, because these are not so frequent situations, so the bigger question is, should we use this stent whenever we believe the stent will be needed on the long term? And this really needs to be studied in a randomized control trial. We are working on it because I believe the tolerance, even in patients with not a particularly complex anatomy, I think when you believe the stent will be needed on the long term, the tolerance will be better. You will have less complication and maybe less stent replacement, less procedure, less hospitalization, and maybe ultimately a higher rate of complete healing again. So in conclusion, and again, this is just based on my experience, we need more data, more published data, but what appears to be clear is that bifurcated cases benefit the most. That's where we struggle more with conventional devices, and in particular in anastomotic complication with distorted airways. Anytime long-term stenting is needed might be another indication. That's the main question, and it needs to be studied through a randomized control trial. The input of the physician is very important. It's a case-by-case approach, and it's time-consuming. It requires a little bit of experience and a learning curve because you need to design the stent anticipating what you can obtain in terms of diameter, for example. The radial force is not so easy to anticipate. It depends on the thickness, the shape, the diameter, a lot of things. What I really suggest and what I strongly suggest is that you don't try to match the anatomy at the stenotic level. Do something tubular that match the biomechanics of what we know with conventional silicone stents and match the anatomy on other parts. That's where you're going to gain in terms of complications. And regarding complication, I really believe it reduces strongly the granulation tissue reaction. It's probably a decreased migration, which again are rare for bifurcated cases, but still. The tolerance is clearly, again, better in my opinion, even though, again, a randomized control trial alone only will prove that. It's still a foreign body, and what I believe is still a complication that you will face is mucus plugging. And another limitation so far is that it's still a two-step mold-based approach. So 3D printed stent don't exist. It's again a mold, an injection mold in which we put the stent, and this means a little bit of turnaround time, 2 to 3 weeks minimum. And if we have to do a randomized control trial, we'll probably also do some medical economic analysis, because obviously they're more expensive, but if you have to use much less, and that's what we see at least in case that benefit the most, if you have less adverse event, less stent replacement, less hospitalization, and higher definitive cure rate, it's probably also interesting to look at the medical economic analysis. And thank you very much for your attention. I hope I was not too long.
Okay, thank you very much, Nicolas, for this very nice presentation and very impressive images. So the third speaker will be Professor Karin Redmond. Karin Redmond is a thoracic surgeon and chief of the Department of Thoracic Surgery of the University Hospital of Dublin in Ireland. Please, Karin, you have the microphone for your presentation about metallic stents.
Great, thank you. Thank you for the opportunity, and I'm delighted to be here speaking with so many learned experts in the field. I'm going to talk a little bit today about metallic stents. As I mentioned, I'm a thoracic and transplant surgeon. My experience probably started off with a senior registrar with Peter Goldstraw in the Brompton before I became a consultant there many years ago. And I've gone through a range of stenting devices, whether it's under local or under GA, flexible or through rigid bronchoscopy. And I've gone from silicone to metal to covered, having been uncovered, straight through to biodegradable stents I've tried, and I've tried the 3D reconstructed stents. So my message to people out there, there's no one ideal situation when it comes to stents, which is why there's a range of products on the market. Having said that, I have been very impressed with my previous speakers, and I have to think about the lessons that I've learned from today. So when to use the stent? Well, it's very important that you have access to a specialist airway MDT, and it's important to understand the benefits of stenting. And as been mentioned by my colleagues, sometimes it's knowing when not to stent. But if they have a very bad dyspnea and you're looking at quality of life, especially in the patients that either have benign or malignant disease, symptomatic hypoxemia, failure to wean from the ventilator. Sometimes you don't actually realize they have airway disease until they can't come off a ventilator. Non-resolving post-obstructive pneumonia where they're septic, especially if they're looking for systemic therapies, and you need to get their sepsis under control. Impending obstruction of the trachea and impending obstruction of a major bronchus that could be life-threatening, or could be life-threatening in the event that they were to get other treatments such as radiotherapy or brachytherapy. It's also important to think about stenting as a bridge to other therapy. For example, I would consider stenting in a cohort of patients that may eventually have a tracheobronchoplasty with me for severe dynamic airway obstruction. So just because you can place a stent does not mean that you should place a stent, and that's where the specialist input from the MDT is important. And I think I mentioned this to my colleagues before we started. It's important to get a network of national and international specialist airway MDTs and have access to a registry with your local group. And the ideal airway stent, well, this has been referred to earlier on. I would say obviously radial force is important, but most stents tend to give me the radial force that I'm looking for. Minimizing granulation tissue is also important. I do wonder whether people are being pre-treated for malignant conditions such as radiotherapy, they get less granulation tissue. And then I look at the other cohort of people who have maybe a nickel allergy. Do they get more granulation tissue? It's an area that we don't fully understand as to why some people get granulation tissue and others don't. Do I get granulation tissue because I'm undersizing my stents and there's a bit of movement causing granulation tissue? Or do I get granulation tissue because I'm oversizing my stents? That's leading to some airway issues. Certainly people have looked at pre-treating the airway prior to stenting, such as injecting steroids, etc. And again, there's a wealth of expertise out there, but not as much published in the literature as one would hope for. And I think it's something that we should look at as a group. We want to minimize tumor ingrowth, be biologically inert, resistant to recompression, flexible for tortuous airway. Some beautiful pictures there, my last speaker. Radiopaque is important, being very practical about this stuff afterwards, that it stays in the place it should stay in and that there's no displacement. And I would say for a large group of people here today, and this is where metallic stents do come in, they are very easy to deploy and, they allow for precise one-handed delivery. And that's actually quite important. You could possibly do these things under local. It's hard around the logistics part of it. Do you have an anaesthetist that's able to manage airway obstruction? If you're going to put people under a GA and you're going to muscle relax them, you're going to lose the airway, you're going to be able to recover the airway. Sometimes going through the focal cords can be tricky with rigid bronchs, and sometimes trying to get some of these stents down really distal in the airway. Your rigid bronch and your telescopic instruments can only go so far. And if you're trying to get very distal into the airway, it can be difficult to do that. Whereas with metallic stents, that's just a little bit easier. And I wonder, is that the reason why we've gone down the route, I think, for a lot of people out there, specialists, are using metallic stents over silicone stents. Virtually no foreshortening of the target site is important, and obviously being easily repositioned or removed post-deployment is also important, which is a problem for metallic stents, and that's what makes people nervous. So the airway stent choice, you have to consider when you're looking at a patient, is it going to be straight? Is it going to be Y? Is it going to be a T-tube? Now we're after getting tailored stents through, which would be helpful. Is it silicone? Is it metallic? Will we have a hybrid? I've tried biodegradable, or will we have treated stents going forward, which will help to reduce, for example, tumor ingrowth or granulation issues? Is it non-flexible or flexible? Is it fixed versus self-expanding? What's the deploying mechanism I'm going to use? Am I going to look for a proximal or a distal release with a metallic stent? It's quite nice to have a proximal release with a metallic stent because when you're just below the focal cords, you want to make sure that when the stent gets deployed, that it doesn't impact on the focal cords, or potentially, at the level of the opening, for example, if you're stenting the left main bronchus, that you can manage that. And is it going to be covered or non-covered? Covered stents are obviously ideal to prevent ingrowth. Traditionally, we didn't use covered stents in the past because we were afraid about obstructing, for example, the right upper lobe bronchus. And if you look at the Ultraflex stent there in the picture, you can see that it's mostly covered, but a small part of it is uncovered at the proximal and distal ends. And that's where the ingrowth will come through, and that's where the stent will hold. It won't, get moved, but it will also be very difficult to remove. And you really need to have a certain level of expertise that if you're going to put a metal stent in, such as this, that you're in a position to take them out. When I went through as a trainee, there was a whole range of metal stents out there that I would have been exposed to, wall stent, alveolar stents, Palmes stents. But in fact, the only metal stent that seems to have survived the market has been the Ultraflex stent, which was being referred to earlier on, and quite a lot of people are still using the Ultraflex stent. Expands to a maximum set diameter. Its major advantage over any other stents is that it does not shorten, and although positioning of the proximal distal lens of the stent is easier, the radial force can be a little bit less, and we know that the silicone stents are a little bit better in that regard. And then came through the Lufin stent, and this has really helped significantly in managing airway conditions with certain stents that are covered, that are easy to deploy, but also when you look at the Lufin stent, you can see that it's mostly covered. Sometimes it's uncovered to allow opening into the right upper lobe bronchus, but it works well. So the Lufin stent is a hybrid Y stent that consists of this thin polyurethane sheet. It has nitinol again, and it's about 5 millimeter area that's uncovered for the right upper lobe. It comes preloaded on a delivery system. and you can put it through at an 8.5 rigid bronchoscope level. For me, I use a size bigger. I can go up to a size, 12 or 14 rigid bronchoscope, because I tend to deploy the stent under visualization, although some people will use IOR. It's important that you've got the bronchoscope with the jet insufflator in place. It has a range of diameters from 16 to 20 and a range of angles. And it's important to look at that with your service provider so that you get it right. And there's a series of guide wires to help you go down the left or the right hand side. Again, they've evolved the stent in itself. You've got radiopaque markers now that work, higher radial expansion force, and certainly it is probably one of the better products out there on the market. And it's probably the only one that's really competing with the UltraFlex stent in my eyes, with less issues in relation to removing the stent. The deploying apparatus has an X-ray mark. There is different areas to put the wires in, and you can see where you can very clearly work out what to do in relation to deploying the stent with straightforward steps and good information on the website. So in the earlier literature, just talking about the reasons for metal stents, you can see there's a couple of publications there, maybe as far back as the 1980s, but no, it doesn't really predate beyond that, where a lot of these stents were being used for malignant disease. And with malignant disease, stenting is there really to palliate dyspnea caused by extrinsic compression, intraluminal disease, or loss of cartilage support. But we would hope that when you're putting a stent in for people who are going down a pathway where their life expectancy is short, traditionally it was like, life expectancy is short, but it should really be over 6 weeks, and that should be discussed at an MDT, adequate performance status, independent of airway limitations, and that they have appropriate anatomy. When I used to think about considering people, I said, are they going to live more than 6 weeks? I'll consider a stent in these people. But now with new systemic therapies coming through, it's quite important to talk to your medical oncologist about how long you expect them to live. And is it reasonable to be putting a stent into somebody? Even people with stage 4 lung cancer who have PD-L1 expression, are responding incredibly well to immunotherapy. And instead of living weeks or months, people are now living years. So when you're putting a stent in, you've got to be mindful about the fact that putting the stent in, this stent could be with this person for a number of years, not a number of weeks or months. And understanding that is important, because all stents can have some level of complication on that patient, and is it reasonable for them? So when you're putting your stent in, the couple of things to look at is whether you should review the CT to establish if the obstruction is proximal or distal. You need to establish on the CT if the obstruction is either fixed or dynamic. Quite often there will be a mix of both. And sometimes you may either underestimate or overestimate the extent of obstruction due to the phase of which the CT has been taken. Ideally, it's nice to have either a cine view where people are breathing in and out, or at least to have a CT with full inspiration and full expiration to understand the fixed and the functional component of the obstruction. The dynamic or functional component of the obstruction may become more obvious to you when you muscle relax the patient, where they go from having an airway to not having an airway, and you need to be in a position to deal with that straight away. Consider inhaled induction in the high-risk cases, maintaining spontaneous ventilation. Consider fiber optic intubation. Consider what size rigid bronchoscope you may need. Make sure you've got the jet insufflator in the room and that it's hooked up to the right axis in relation to oxygenating the patient, and make sure that you're happy that when you do view, which I'd often do view the vocal cords through a laryngeal mouth before I start, that you're happy that the rigid bronchoscope will get through the vocal cords without causing too much disruption or damage to the vocal cords. The most important thing is to have trained personnel in the operating room with you, with the availability of telescopic grasping forceps, debulking instruments or guide wires, and obviously the range of stents that may be available for you when you're doing your surgery. So when you go in, you may actually find that it's actually hard to deploy the stent without having some kind of desobliteration technique available to you to get rid of any tumor that might be there. Certainly in our unit, we have cryo, we have argon, we have laser, we use diathermy to debride, and it just depends on what instruments are available and what you're comfortable with, and that you can manage this. It's important to have those options there available for you. It's also important to make sure that the image intensifier is in the room in case you need help to actually deploy stents using IR. Although for me, I don't wait for the radiographer or the image intensifier. I tend to do it under direct visualization. It's also important to realize how sick these people are and whether you are going to lose an airway at induction of general anesthesia. And there have been cases for me where, we've had to, we would preempt that and use ECMO. So we would put the patients on awake ECMO through the groin, and then this is a very controlled setup for basically putting the patient to sleep, reviewing the airway, and appropriately stenting. This is rare. Most patients, you should be able to get them through and to manage what needs to be done, but in the rare event, it may be problematic. Going from malignant to benign disease, again, the dynamic component is important to note, and I just wanted to show these images today showing on CT with reconstruction how the dynamic phase is important, and this is probably important for the newer 3D stents that are coming through, that you're actually looking at the images on inspiration and expiration so that you don't either oversize or undersize the stents. That can lead to complications. That has been my experience with it. And so giving an example of somebody with bad malacia in the airway, this patient actually has been diagnosed with Vergnon's. And in fact, I was dealing with a proximal airway stenosis, just a subglottic stenosis just below the vocal cords. And I was, doing a Mercedes-Benz incision to open it up with dilatation, because you don't tend to resect subglottic stenosis for patients with Vergnor's. You're waiting on systemic therapy with your rheumatologist to deal with the problem. But I suddenly noticed distal to the problem that she actually had quite bad malacia as well. And so every time she stenosed down because of her problem, it was more prevalent, the symptoms. She couldn't lie flat simply because she had not just one issue, she had more than one issue. And it's important to anticipate that in some of these patients with systemic conditions such as polyarthritis nodosa or Vergnor's, etc. And traditionally in the past, we would have used multiple stents for polychondritis. This is an old X-ray from many years ago. But now with newer biologics, you would hope that this is not the case. And with the introduction of better placed, I would think, 3D silicone stents, hopefully this will be a bridge to systemic therapy to allow the disease to settle down and remove the stent at a later stage. I've had to use ultra-flex stents, covered stents in difficult situations where there's been massive air leaks. For example, there's an example of a gentleman of mine who was a trauma case who'd been crushed behind an articulated truck. He actually had completely obliterated his right main bronchus off. He needed a right pneumonectomy, but he had a tear all the way up because of the crush injury, all the way up his trachea, up to below the vocal cords. And we had to put in multiple covered ultraflex stents quite quickly and quite promptly, as well as taking his right lung to keep him alive. This is an example of the ultraflex stent being deployed in the airway. In the end, we had to basically fill his chest because of infection. At a later stage, I needed to take the stents out. The stents coming out, they did come out, but you do need, again, your choice of argon, laser, etc., to take the ingrowth away from the uncovered part of the stent to be able to take them out. But he had 3 or 4 overlapping ultraflex stents, and I took them out at a later stage. This is something that I would not encourage to do in centres where you don't have the surgical expertise or interventional bronchoscopy expertise to take these stents out, because they are tricky and it can lead to issues and complications. So with the metal stent, there are some advantages, and some disadvantages. And some of the advantages and disadvantages are the same. Like being permanent may be, in fact, an advantage. The thing I would say most about the metal stents, it's quite nice for interventional bronchoscopies to have access to them when you can do it without a general anaesthetic, under local anaesthetic, and you don't need the additional support in theatre for that. However, the disadvantages, I think, is stent fracture and sometimes cough, especially if you in any way consider using these stents in people with benign disease, which is something I try to avoid. The complications of metal stents, mucus impaction, granuloma formation, reobstruction, infection, hemoptysis, pain or cough, stent migration, fracture, and allergy. As I said, up to 10% of the population have a nickel allergy, and we just have to be mindful that there may be a link. Certainly when I'm putting bars into patients with pectus conditions, I always get them allergy tested, but we don't allergy test for other nickel products out there, including products in the airway. If you talk to the immunologists, they would say they're less worried about an issue linked to allergy or hypersensitivity, pneumonitis, hypersensitivity reaction linked to stents. However, they're more thinking about developing a rash or a headache or something like that, whereas I'd be more thinking about the granulation growth in the airway. So other complications can be either pneumothorax or secretions. And here's an example of a Lufin stent that's gone into somebody that I used temporarily for tracheobronchial malacia. And if you look down here on the right-hand side, you see that the back wall always comes up to meet the front wall in people with dynamic airway obstruction. And the fracture will often happen in the midpoint of the back wall. And you can see the fracture there on the right-hand side in the picture. And so I had to take the stent out. I think I nearly lost the nerve a digital nerve to my thumb trying to remove it at the time, and it needed to be cored out of the airway to remove the stent. And this is a picture I'm showing you just to show how difficult this can be with any form of metal stent, whether they're covered or uncovered. Obviously, the covered stent, you wouldn't expect this to happen, but fracture can happen, and it can lead to difficulties such as this. Stents can also erode through the airway. It's an example of a relatively young lady who came to me who'd had an esophageal stent put in that eroded through the back wall of the trachea. And so I actually stented the trachea and pushed it back into the esophagus and made it the problem of the GI physician, who subsequently then stented the esophagus. And in fairness to this lady, she actually lived another 3 years following her difficulties, because the difficulties were linked locally to obstruction at the level of the esophagus and the airway, and further down her airway was pristine and she could ventilate and oxygenate fine. So erosion through can also be problematic. We did look at the survival between malignant and non-malignant groups when I looked at Peter Goldstraw's cohort years ago. And you can see that, there can be difficulties not just with malignancy, but also in non-malignant conditions. We've got to be mindful about that. And I certainly would encourage registries in this area, especially in the era of new biologics and new targeted medicines for people with malignancy, because I do think survival is better than it was before. And finally, just to say with metal stents and all stents for that matter, it's not just about the preoperative decision-making and the role of the MDT, but also post-operative management. And it's something that we often forget about. There is actually no studies out there supporting any particular medical intervention after stent replacement, and each centre probably have their own policy. But certainly, look at the role of the flutter valve or the a cappella to release secretions and get it up, having had nebulizers, using Embexpotex and azithromycin in a certain cohort of people that suit to try and reduce the infection risk. Thank you very much.
Okay, thank you very much, Karine, for this excellent talk. I think you have time now for discussion. I have received some questions from the audience, and two of these questions are about the difficulties to insert 3D printed silicone stents. And the question is about the devices. Is the devices available, useful to insert these very complex imaging 3D stents? So the question is about for Nicolas and perhaps Hervè. Could you answer, please?
So I just use the usual loading system from Novatec, and when they're really large, when they're really wide, I just insert them directly through the larger tube that I can intubate the patient with. But usually I use the same loading system, the Novatec system for me, but I think all of them could be extrapolated.
Okay. Hervé, another answer to complete the answer or not?
No, not really. Nicolas has clearly the higher experience in that, and only few times I did 3D printed statement. I use the same stent applicators, loading system. Well, you mentioned the Novatec one. It's the Tone applicator, Hermann Tone, the German physician. So it's very useful for large airways, large stents. So no, I have no problems regarding this placement.
Okay, thanks. I have another question from the audience about tracheoesophageal fistula. The question is it better to start with esophageal stent or with the tracheal stent due to the necrosis of the posterior part of the trachea? So the answer is for the three speakers, I think.
But if you don't, if you don't mind, I can start.
Yeah.
But you have, I can answer. I have a double answer. So you have the theoretical answer, which says that when you place a esophageal stent, there is a risk of secondary compression of the airway and of respiratory distress. So I know that some authors have stated that it was better to start with airway stent. This is theoretical, because for me, and I think for Nicolas is the same, if in this situation, the esophageal stent alone is enough to seal the aspiration, it's enough. There is no need to place airway stent because you enlarge, you worsen the situation because your fistula is taken in sandwich between the two stents and you enlarge the situation. So practically, we prefer esophageal stenting alone, and only if there is secondary compression of the airway or persistent aspiration, then we'll place airway stent. But again, esophageal stent alone, so first. That's my answer.
Okay.
I'm happy to.
Yes, Karen.
We have a number of people with TOFs, unfortunately. We tend to go with an esophageal stent if the esophageal stent will hold. Sometimes the esophageal stent won't hold. So I kind of take the opinion of the GI physician or the GI surgeon as to whether the stent will hold, and I will always go with an esophageal stent. If that's not the case, then we've been using the Lufen Y stents. For these fistulas, they're often lower down, and that's worked well for us. You know, we haven't had a lot of difficulties with the use of the Lufen Y stent in this particular cohort.
And I wanted to add that an esophageal stent is always better tolerated clinically than airway stent. Airway stent, it's a foreign body in the airway. Having foreign bodies in the esophagus is somehow more normal than in the airway. So the tolerance, clinical tolerance, will be always better. If one stent is necessary, it will always be better in the GI tract.
Okay. I have received other question. A question to Karen. What were the indications for removal metallic stents you have shown in your presentation? Have you cases of removal metallic stents, and in what's the indication for that in your experience?
Yes, I've removed quite a few. Sometimes the metallic stents have been put in by other centers for benign disease, and then they recognize they run into issues with granulation ingrowth and further stenosis or recurrent infections, especially in people who might be immunosuppressed for other reasons. So we would take the stents out. I've had stents removed, such as the Lufen stent that I showed in the picture that had fractured, for people with severe dynamic airway obstruction, and I've actually more and more, as I've gone through my experience with tracheobronchoplasty, have almost gone direct to tracheobronchoplasty, then using an interim stent to see if they get symptom control or not. If I'm happy that over 90% of the airway is obliterated and they clearly have the symptoms linked to TBN and no other causes for their dyspnea. So I think that's why the MDT is important, to make sure that whether it's benign or malignant disease, what's the life expectancy of this person? And do we expect this person to run into problems with complications with their stents that would require the stent to be removed in advance of them actually dying, And it's all about quality of life, is giving them back quality of life and giving them survival. So I would be very cautious about using uncovered metal stents in anybody where you would expect them to have any survival more than a number of weeks. Probably if they're getting radiotherapy, the airway tends to cope better with less stenosis, I find, and less cough. Maybe because it denervates the airway a little bit if they get radiotherapy. But if they're in, for malignant conditions that where you expect them to live that little bit longer, but otherwise, yeah, I'd be very careful about your stent choice and selection in benign disease.
Okay, thank you. I have received another question about post-tuberculosis stenosis. Is what type of stent is, in your opinion, better in this type of benign stenosis, very frequent in many countries?
But if I can start, if you want. Yeah. First, it's benign. It's benign. We all agree that it's a benign stenosis, and finally, when you look clearly at precisely at all benign stenosis, whatever the etiology, the etiology could be infectious, like in TB. It can be cough of a balloon for benign tracheal stenosis after tracheostomy. But what I mean is that you have an aggression. You have an aggression, and then after you have the healing process, and post-TB stenosis, it's like any kind of fibrotic stenosis. So that means that they have to be treated all the same. And in my opinion, it's benign. So you have to put a removable stent. And in my opinion, removable means silicone and fully covered metallic stent. So I would never place something which is not fully covered in this kind of situation.
Okay. Karen, a complementary answer?
I tend to use the Novatech silicone stents with the anti-strut mechanism for these people. It's often the left main. I have used 3D stents and biodegradable stents in the past as well. I think it's very important, this concept of active inflammation versus no active inflammation. If people have active inflammation, any manipulation of the airway just causes more inflammation. So I've had people with complex systemic conditions, or I had a lady who was in a fire before, for example, and I could not get the inflammation to settle down without putting them on high dose biologics to try and settle it down. But I recognized the more I was doing with the airway, the more problems I was causing. So I personally think that an inert silicone stent, whether it's, pre-made off the shelf or whether it's 3D made, is the best situation for these people. And again, sometimes they have fixed fibrotic stenosis, and they'll also have a little bit of malacia at the proximal end or the distal end. And so you need to understand that and how much you need to cover the airway, what's needed for the patient. I probably have about 3 or 4 people, not very many, with TB or, post-TB bronchiectatic lung with left main stem stenosis. And they're all out there with these silicone stents and living very normal lives and not running into problems with either cough or mucus production or migration.
Jean-Michel, maybe I just wanted to add something, and because it's important, and Karen said it. At the inflammatory phase, there is no place for stenting, because you had an inflammation etiology with the stent. So and when it's inflammatory, that means that there is a possibility with medical pharmaceutical drugs to reduce the inflammation. So the inflammatory phase is clearly not a good indication for stenting. And Karen, you were mentioning relapsing polychondritis, but I have no big experience on that. But when I look at the acute phase of relapsing polychondritis, I won't dare to place a stent in this situation when you have circumferential edema everywhere. So I guess you place stent when after the healing process has been done, after the acute phase.
Yes. And you only put them in the acute phase when you can't get them off a ventilator, or do you know what I mean, that they're really, really sick. If you're really stuck, that you're trying to keep their airway open. But beyond that, I avoid any manipulation or stenting during the acute phases.
Okay.
Thanks. I have a question for Nicolas. The thickness of 3D stent is equally or not, because the tension pressure are different in each area. What's about the thickness of a 3D printed stents? I know there is at the beginning some problem about that. Nicolas, you can answer?
Well, the thickness, theoretically, you can choose the thickness that you want. Usually, we know that below 1.2, the radial force becomes really unpredictable. So the minimum is 1.2, and you can do also, in theory, you can do different layers at different areas of the stent. So do 1.5 at the stenotic level and 1.2 on the less, on the more, on the other parts, but usually it's 1.2 to 1.5. You can choose. You choose depending on the diameter also. The larger it is, the thicker you need to do it. So in theory, you can do whatever you want, but we tend to match what we know with Novatec, with the Dumont stent, classical Dumont stent. So
okay, I have a question for the three speakers. With the efficacy now or new treatment of lung cancer, for example, immunotherapy, stent could be considered as a neoadjuvant therapy. So do you think that in the future, removable stent will be the right solution to weight the efficacy of systemic treatment of lung cancer? And have you any experience or data about this strategy using IP and stents as a bridge to weight the efficacy of systemic treatment of lung cancer? It's for the three speakers.
But I think Nicolas can speak about that, no? Because you have we have published recently few papers regarding that. Nicolas, you want?
I think you can talk about Spock, no?
Yeah, okay, I can speak about
I know.
Spock because I was the first author of this paper. It was in 2000, I don't remember. What time? 2020, no? Spock. Silicone prosthesis in obstructive lung cancer. It's nothing related to Star Trek. It's a Spock study. It was the first randomized study in therapeutic bronchoscopy. So the question was simple. So you have a patient suffering from a symptomatic airway obstruction due to malignancy. You go to therapeutic bronchoscopy. You have a good technical success of your bronchoscopy, therapeutic bronchoscopy, because you reopen the airway of more than 50%. So the patient is reopened. The question was, do we have to place a stent in order to prevent local recurrence, or do we don't place a stent, or we don't place a stent, so we don't expose the patient to stent-related complication, but we expose the patient to local recurrence? Which behavior is the best? And then we have some results regarding that, and statistically we found that placing a stent was only beneficial for patients who failed from the first line of oncologic treatment. Generally, it was chemo. But for the patient who naive from any oncologic treatment, there is no benefit to place a stent. So, but it's not really the answer to the question. The question was about placing a stent, but I guess for symptomatic obstruction, for compression, waiting for chemotherapy to relieve the compression. This is how I understood the question. But on this special question, we don't have really data. I hope soon, because with the French group, I'm working with two fellows on two questions. It's one about small cell carcinoma and one for lymphoma. We know these two entities are quite chemosensible. And so I cannot give you the data, but clearly when someone is in respiratory distress, because of compression of the airway, placing temporary stent, then sending the patient to chemo and remove the stent after efficient chemotherapy is clearly good solution for these patients. But I don't have the precise data. From my experience, clearly, it's a good, very good solution, mainly in lymphomas.
Okay. I have
Can I make a comment there as well?
Yes, sorry. Yes.
Yeah, the pathways for lung cancer are changing so much. You know, if you look at all the surgical trials, are we doing segmentectomies or lobectomies? You know, for example, you know, in the trials coming through, but also the role of immunotherapy. So NICE in the UK are now having to, even though they submitted their last statement in 2019, they have to go back and do a revision because things are changing so much. For example, there was a paper in Nature a couple of weeks ago looking at the role of neoadjuvant immunotherapy in T1B and above lung cancers. And certainly we're now recruiting to the NeoCOAST Lung 2 trial, where we're looking at resectable lung cancer up to stage 3A, but we're going from 2A up to 3A, where we're offering neoadjuvant chemo IO prior to surgery. And we are seeing up to a 20% complete pathological response rate to immunotherapy in the right cohort of people with lung cancer. So I suppose it's a good question around the role of stenting in people that, you know, may have curative lung disease, but even our understanding of, you know, what is curative lung disease and what isn't, I think will change. You know, we look at kind of the risk of recurrence in stage 3A. I think that's going to change with immunotherapy. The risk of or the, you know, survival benefits from immunotherapy in stage 4 lung disease, I think will change. So I see your point about stenting. I suppose it's something I hadn't thought about before. You know, when you look at these new lung cancer pathways, maybe we do need to look at the role of stenting, and not only when we should stent, but what we should stent with, because people are certainly going to live longer, and some people who we couldn't cure before will be cured of their lung disease. And whether they've got residual airway problems after it, I don't know, which will have to be maybe managed. I've seen some fantastic cases today from my 2 expert colleagues. So I think it's a really interesting field, and certainly will lend to a better care for patients going forward.
Jean-Michel, maybe I can
Yes.
add something. We are today we are focused on airway stenting, but airway stenting is just part of the armamentum of therapeutic bronchoscopy. So it's better to therapeutic bronchoscopy rather than just stents. From the French registry, it was surprising to see that in this registry we have included all patients suffering from symptomatic obstruction of central airways due to cancer. So symptomatic obstruction. And what we found is that more than 50% of the patients going to therapeutic bronchoscopy were naive from any oncologic treatment. So in other words, they come into the disease with obstruction, the symptomatic obstruction. So we, as interventional pulmonologists or thoracic surgeon, Karen, we are neoadjuvant treatment. We are the first treatment in, I'm not going to say about for more than 50% of lung cancer, but 50% of lung cancer suffering from airway obstruction, which is still a big amount of patients. And so we have to do something. We have to reopen the airway before oncology treatment. Okay, we have improvement in oncology treatment, but if someone is suffering from respiratory distress, we have to do something before oncology treatment. And we do it in more than 50% of the cases, which is interesting to know.
Okay, thanks. I have received many questions. So another one, in severe tracheobronchomalacia, what's the best stent to use? It's a question on debate. What do you think about that? Is it a place for a stent in tracheobronchomalacia or not?
But again, because I'm used to speak first, so at least we have 2 papers. One from Henry Colt, one from Armin Ernst. They published a series of patients, and in both cases, but it was with silicone stents. Short-term effect is an improvement, subjective improvement. Long-term result is a mess. So you have more than 85% of complications with granulation, obstruction. Well, so now I think that stents are not indicated for tracheal bronchodilation, except, and Karen, you know this indication, is to select patients who will undergo surgery for tracheal bronchoplasty. So I heard that you don't do it anymore, but in France, we have a expert in France is Emmanuel Martineau, the guy who does aortic tracheal replacement with aorta. He still use stent trial. So he places a wide stent for a short period of time. If patient improves, then he operates them. That's the only indication for stenting, to my knowledge, in this situation. Otherwise, it's palliative and it's a mess.
Okay, Karen,
I would
probably
agree.
yes.
No, I would agree. I found I only started doing tracheal bronchoplasties because I found it was a mess stenting people for dynamic airway obstruction, and then I realized, that actually the surgery of tracheal bronchoplasty for me was probably less morbid than the stent trial itself. So the thing is there are some people who may have multiple comorbidities. They're overweight, they may have some reflux, they may have some underlying cardiac disease. So sometimes the trial of stenting is helpful in those people to see, is it going to actually give them the symptom relief that they're hoping for? And then in other people, I would just go straight to tracheal bronchoplasty. And the length of stay, with tracheal bronchoplasty in hospital is probably, maybe for me, is about 3 or 4 days. It's actually not as onerous an operation as people would foresee. And definitely within the surgical world, I think we have to do this more. We have to train people and have specialist airway centres, certainly within Great Britain and Ireland, to basically support patients with dynamic airway obstruction, because I think there's a lot more out there than we realise, I am slow to offer surgery. Like they really have to jump through many, many hoops, including, weight loss, optimization of any asthma, cardiac conditions, reflux, etc., before I'll consider them. So I'll trial them either with the Lufin Y stent, but I don't want to leave it in too long because I've had that problem with the fracture, or a silicone Y stent.
Okay, I expect to have time enough for other questions. I have received many questions. For example, Dr. Jordanov from Bulgaria thanks to question about place of artificial intelligence in stenting. Have you any suggestion about that?
Not
Or
really.
speaker?
I don't know. Maybe in the design of the stents, but I'm not expert in AI, so maybe to design some personalized stents, but I don't know, Hervé, if you see any other.
I'm not intelligent enough.
No.
I think with the dynamic component of the airway, it would be nice to have AI involved in, making these stents, big but not too big, small but not too small, getting it right. I don't know what the ideal size is for my airways, to be honest. I have never worked out whether I should, how do I size it? Am I oversizing? Am I undersizing it to prevent problems or complications? Da Vinci have a new robotic bronchoscope system through called the ION. I'd be interested to see, is that just a step towards something linked to AI, where we'll be taken out of the equation and the robots will be doing it.
That would be interesting to ask to ChatGPT the question: what is the ideal airway stent? and find out what is the answer. I think I'll do it after. I'll do it. I will go on ChatGPT.
Well, let us know.
Yeah, maybe I could try.
I have another question. It's a complex answer, probably. It's a question about prophylactic airway stenting in patients with non-significant airway narrowing, referred to radiotherapy, to minimize the risk of airway compromise from edema or other complications. So you have often this type of question: is it useful to put a stent to prevent a possible complication or possible bronchial stenosis? What's your opinion about that?
Well, so my opinion is that airway stenting, like therapeutic bronchoscopy, is a symptomatic treatment. So that means that, at least in my philosophy, that means that you have symptoms. You need symptoms. But you need symptoms to do something. So the prophylactic stent placement for me is not really my my habit. You know, and generally I say no. I say no because when you put a stent, you bring symptoms. So you will create symptoms in someone who doesn't have symptoms to prevent something that maybe won't happen. So my answer is no.
Okay. And Karine or Nicolas, have you the same answer?
Yes, I have the same answer. So when someone is worried about the CT aspect of a stenosis but the patient has no symptom, I don't treat them, but I stay very reactive. If the patient have symptoms, I know that I will have a short delay to proceed. So that's usually my answer to
Okay.
to the anxiety of.
And Karine, do you put a stent preventively or not?
If the patient struggles to lie flat, they'll struggle to get their radiation treatment. So they're symptomatic. So those people I will offer it. And sometimes I consider a stent if the radiation oncologist won't treat the patient without the stent being put in, because they need their treatment. So if they're incredibly anxious or nervous, even on steroids around administering radiotherapy, then I will consider putting a temporary stent into those people. But as I completely agree with my colleagues, I think less is more.
Okay. I don't know if we have time enough for other questions, but I received many questions directly online, and there is several questions about diameter and length of stents. What the principle to select the best length, the best diameter, either in silicone or in fully covered metallic stent. Do you
Yes,
propose a short answer for each type of stent?
Alors, short answer, if you don't mind, Jean-Michel. So Dr. Dumont, so pioneer in airway stenting, used to tell me, put the largest and the shortest stent you can. So largest means that you have to achieve the ideal dilation. And shortest, that means that you have to place a stent just the length of the condition, plus 5 millimeter each side. But if you want a more precise answer, the selection of the diameter of silicone stent depends on two things. First, it depends on the diameter of the ridge bronchoscope you have been able to pass through, either the stenosis or the malignancy. So I take an example. If you take the Novatec bronchoscope on the trachea and you pass the largest bronchoscope, which is 14 millimeter in diameter, that means that you can place stent from 18 to 15. And then the second factor beside the diameter of the tube is the tactile feedback. I mean, in other words, the force you have to apply to pass through. If it's very fibrotic stenosis and it's very hard to pass the biggest tube, then you have to among 18 to 15, you have to place 15. But if you pass easily, you will place 18. That's for silicone. And for metallic, maybe Karen will comment, but you have to add 2 millimeter more than the diameter of a silicone stent. If you place a 16 millimeter silicone stent in the trachea, that means that you can place 18 in metallic. That's basic rules. But even with basic rules, I still can make mistakes from time to time. You know, it can happen. diameter is difficult sometimes.
Okay. Karin, a complementary answer concerning metallic stents?
Yeah, I tried to go as big a size as I possibly can. I would agree. If you look at the left main or the right, for example, you know, I am up there at a 12, 14, 16, you know, at least.
Yeah, 14, 16, yes.
14, 16. And then in the airway, it's funny when you actually look at the, you know, the upper size stents are 20, but actually, you know, which is the nice thing about these new 3D reconstructed stents, you know, you get a lot of people with a component of almost tracheomegaly, you know, and, you know, do you want a 22 or 24 or even a 26 in people's tracheal areas? But the problem is the deploying mechanism. Can you actually get it through the vocal cords to sit where it needs to sit? And sometimes the other issue is, can you deploy it down distally enough with the instrumentation that you have? That's been my tricky bit. I've seen some lovely ones of your dealing with your post-transplant anastomotic issues in the bronchus intermedius. I have to say, Nicolas, I was very impressed. And getting into the right upper lobe there was a beautiful picture there from Hervè too about that. But it's, you know, sometimes the sizing of the stents is about, can you get them through the vocal cords and how distally you need to get them? So it's a kind of a, you know, it's logistics, and sometimes the sizing of the stent is about the airway and the pathology. So I tend to go, at least if I can get a 14 or 16 or even 18 into the main bronchi, I will. And I just wish there were stents that were bigger than what's available out there for the trachea. The length of the stents, for me, it sometimes depends on what's available to me, to be frank. And if you're doing airway work, you should have a nice consignment with your supplier and have a range of stents available to you, and a range of proximal or distal release stents available for you as well from the metallic range. So sometimes I end up putting something longer in the left main because that's what's available to me rather than what's ideal, you know. So the only lesson I would take from that, if you're trying to keep them as short as possible, just make sure you've got the range of stent options out there available to you.
But you see, Karen, the good point with silicone stent is that if you don't have the precise length, you can cut. You can cut.
I've done all sorts to the silicone stents in the past. It's like playing Lego. Lego, you're building, you don't know what you're building, and at the end of it, you've got something that works, you know?
It's fun.
Okay.
Although, in fairness, the theatre nurses don't look impressed at the time, though. You know, they're horrified when they're watching you as you mold away. You know, so the 3D stents, I think, will be nice going forward.
Okay, thanks. Michael, is it time to close the webinar now?
We cannot hear you, Michael. Microphone.
Yes, thank you very much for participating. We have a very big audience tonight and certainly a lot of questions. We can't go through them all, and it is indeed time.
Okay, thanks.
Yes.
Thanks. So thanks for the three speakers for their very, very interesting and complementary talks. And thanks for the audience for very, very active participations and many, many questions. We hope that we answer the majority of questions because no time enough. And it's time now to close with webinar. I hope you appreciate with WABIP webinar, and see you soon in a new webinar on another topic. Bye-bye.
Thank you very much.
Thank you. Enjoy your day. Bye-bye.
Ciao.